Warm evening to everybody. Good evening to everybody. And we'd like to welcome you on the behalf of the Society of Otolaryngologists of Nepal and on the behalf of the CIPLA in this webinar, Current Trend in Management of Allergic Rhinitis. We have three expert panelists today. Let me introduce them. So our first panelist is Associate Professor Dr. URMILA GURUNG, who is currently working in the Rhinology, Allergy and Anti-Skull-based Surgery Unit in the Department of ENT and Head and Neck Surgery to Teaching Hospital since 2008. She has got her training in advanced course on allergy and immunotherapy, allergy, asthma, ENT clinic in Bangalore in 2030, and she have more than 25 publications in her cats. Our second panelist, Associate Professor Dr. BIKASH SHRESTHA, Head of the Department of ENT and Head and Neck Surgery, Dhulikhel Hospital, Kathmandu University Hospital, who is working as an ENT consultant since 2009. He has got more than 10 specialty training and fellowship, and he has been trained in allergy and immunotherapy at Siraj Hospital, Mahidol University, Bangkok in 2010. And see his publications, he has got more than 54 publications in his lab. Our third panelist is Dr. RISHI BHATTA, who has done his fellowship in rhinology and anti-skull-based surgery from University of British Columbia, Vancouver, Canada. And he was a former associate professor in NEPAL Medical College, who has been working as ENT consultant since 2010. Currently, Dr. Bhatta, he works in the Department of ENT and Head and Neck Surgery, Civil Service Hospital, Kathmandu, Nepal, and he has got more than 20 publications on this cap. So I welcome all the panelists today in this beautiful session. So we all know allergic rhinitis is one of the most common chronic non-communicable morbidities or disease existing. The incidence is about, it varies from study to studies. So normally we can tell that incidence varies from 1% to 39.7%. And in some study in China, in Asia, it has shown that it is so prevalent, it is prevalent up to 40% of the population. So it is very, 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 very prevalent disease. So in that context, I'd like to ask this question to Dr. URMILA GURUNG, that we know that we give very less time, we have got very less time to give to our individual patient in our clinic. So in your practice, how do you diagnose a case of allergic rhinitis in your busy OPD and differentiate it from other form of rhinitis? Dr. Guru.
Hello, am I audible? Okay. Thank you for the introduction, Dr. Yogesh. So it's my pleasure to be part of this webinar on allergic rhinitis today, which has been conducted by Seoul, Nepal and CIPLA. Thank you so much. And can I have the previous slide, please? So as Dr. Yogesh has already introduced that allergic rhinitis is quite prevalent all over the world. Nepal is no different. In the place where I work, it consists of 2% of the total outpatient consultations, which are basically allergic rhinitis patients. Next slide, please. So we do get quite a large number of patients, and I think it's the same for other centers as well. So how do we diagnose a case of allergic rhinitis? Is it really allergy that we're looking at? So basically the diagnosis of allergic rhinitis is based on the symptomatology, the evidence of exposure to allergen, and also the evidence of allergen sensitization. But here, the history is key to coming to a diagnosis, because we have rhinitis which are very similar to our symptoms, and that would otherwise. So there's always bilateral clear nasal discharge discharge, bilateral nasal, with or without symptoms of itching of the nose, throat, eyes, skin, which would indicate other allergic manifestations like allergic rhinoconjunctivitis or atopic dermatitis, or they could be associated symptoms associated with allergic asthma as well. Here in the history itself, we could probably, from the history itself, we can probably rule out vasomotor rhinitis, which those patients are less likely to have this itching and itching of the eyes, nose, and skin, and any symptoms of bronchial asthma. And they're probably of the older age group rather than a younger age group. So that would probably lead towards vasomotor rhinitis as they commonly present with bilateral nasal discharge or nasal blockage. The other key thing that we have to ask is the diurnal variation. I'm elaborating more on the history because it's quite important. Even if we're in a busy practice, this plays a key role. In the diurnal variation, allergens which are likely to be indoors are mostly the house dust mites are likely to cause symptoms early in the morning. If the patient says the symptoms are more aggravated during office hours, then that probably would indicate occupational rhinitis, like for healthcare workers working in the hospital, or lab workers working in the labs, librarians working in their respective libraries. They get aggravated during the work time, then it would indicate occupational rhinitis. And duration-wise, if it is a long-term symptom, then it would be indicative of atopy. So there are certain triggers preceding symptoms of allergic rhinitis. If the triggers are, or if the patient gets aggravation of symptoms more indoors, then it would indicate the triggers are within in the house itself. Like commonly, if you have pets like cats and dogs, they could be a trigger. If the symptoms are triggered when you're dusting, then probably it's house dust mites. You could be allergic to cockroaches or house moths. If you're indoor and with these symptoms, if they get triggered, then it would be more indicative of that. But if you're going out outdoors, probably in the blooming season, then probably it would indicate pollen as the main cause of allergic rhinitis. And the triggers could be also environmental causes, like if there is any change in the environment, then that can also trigger allergic rhinitis. But that can happen even so in vasomotor rhinitis, so it's a bit non-specific. The severity of symptoms should also be questioned, because based on that, the treatment modality can change. So and the quality of life, how much of it is affected, also needs to be considered. Whether the disease has progressed over the years also is important, because we might have to upscale the management, treatment management. Patients may have seasonal variation in case of seasonal allergic rhinitis, more so to do with the pollen allergy, and others can have it throughout the year. There are most of the house dust mites. Next, please. So family history is also important, as if there is a family member with allergic rhinitis, then it would suggest allergy in the family. Past medical history of allergy in the childhood would also indicate allergy if the patient is present with the symptoms I just mentioned. In the medical history, endocrinological disorders like hypothyroidism or acromegaly have to be ruled out, because they could be a source of hormonal rhinitis as well. Menstrual history in case of a female patient is quite important, because the medications that we prescribe would definitely differ if the patient is pregnant. And also there is an entity called rhinitis of pregnancy, which has to be managed differently as compared to the rest of the patients with allergic rhinitis. Medication history is also important. we have to assess what current medications or previous anti-allergy medications have been tried. So based on that, we might have to change it, or also to check whether they've been complying to the medications properly. Use of topical decongestant also needs to be seen. And some drugs, like the beta blockers or the ACE inhibitors, OCP, can also cause symptoms similar to allergic rhinitis, but they are more of drug-induced rhinitis rather than allergic rhinitis. Coming to the general examination, we would definitely see signs of atopy in case of allergic rhinitis, like allergic crease, sinus, allergic cape, or allergic rhinoconjunctivitis, eczema. Next slide, please. And on anti-rhinoscopy, the mucosa would look pale, the turbinates would be hypertrophied, the mucus secretion would be very thin, and we need to do nasoendoscopic evaluation in all the cases, because there are conditions like chronic rhinosinusitis with polyp or without polyp, which could simulate conditions of allergic rhinitis, and especially if there is a deviated nasal septum, because there could be some sinister pathology lurking behind. And examination of the ears and the respiratory system is also important if there is associated bronchial asthma as well. Yogesh, you could change to the next slide. I'm done with this.
For this, thank you. So right now, I'd like to have any additional comments from our other panelists. Dr. Bikash, would you like to add something that we can, or you are okay with her?
Am I audible?
Yeah, you're audible.
Yeah, thank you, Dr. Yogesh and the Seoul, Nepal and CIPLA for providing this opportunity to speak about this recent trend is allergic rhinitis. And I think whatever Dr. URMILA said is quite okay, because the symptoms and the science and this history taking, whatever she said, I think it's okay.
Yeah. And Dr. Rishi, do you like to add something? Or?
Yeah, good evening, Dr. Yogesh and all the participants. Am I audible?
Yeah, you're audible.
And thank you, Seoul, Nepal, for providing this platform, and thank you, CIPLA, for sponsoring this webinar. And thank you, Seoul, for choosing this topic of allergic rhinitis today, because it seems like a very simple topic, but it has got a lot of complexity in it. We'll find it out as the webinar goes on. Now, regarding the presentation done by Dr. URMILA, I think it was comprehensive, almost including all the areas that one should think whenever tries to go for history. And examination is basically to rule out other diseases like structural pathology or maybe polyps. So more or less, I think she has covered almost all the areas.
Okay, thank you so much. Thank you. So we know we have this classification of the allergic rhinitis, so which is there as like intermittent, persistent, when there is a symptoms less than 4 days a week and for less than 4 weeks a month, and another is more than 4 days a week and for more than 4 weeks, with mild and moderate to severe. Do we, any of us, normally when we write a diagnosis, do we use this classification or we just use a generic classification? Dr. Bikash.
Yeah, basically in our setup, in our hospital, I prefer this generic classification as you mentioned, that is seasonal or the perennial, because this intermittent and persistent classification is good, but there are certain fallacies in this classification also. Like it says that there is less than 4 days per week and for less than 4 weeks, and if there is the more than 4 days, like 5 days a week or more than 5 weeks or something like that, then there is the bit difficult in using this classification.
Okay. Can mild and moderate could be used? Mild and moderate and severe could be used?
Yes, definitely. Mild, moderate, and severe we can use, and yes, definitely, why not?
Dr. Rishi?
Yeah, to be frank, I do not use this classification in usual way. More or less, like this classification was given 10-15 years back, and this has replaced the old classification of seasonal and perennial, and that was a better move by area. The allergic rhinitis and its impact in asthma, that we all know, better move because it assesses the problem of the patient, the severity and the magnitude and the frequency of the symptoms in a better way. Why I don't use is because if you go through the prevalence of each category by different studies, now we find that almost 60% of the patients are in moderately severe and persistent variant of allergic rhinitis. That means by default, whatever patient we are seeing are in that category. And rest 40%, out of that 40% also, approximately 15% of them are having mild intermittent. And these are not coming to us. These are going for the treatment from over the counter. So what you are covering almost like 3/4 of the patient of allergic rhinitis, just not saying like it is persistent or moderately severe, which in fact should not have been done. Ideally, you should write. But as you already said that in busy scenario, you're not, you
able
do
to
not
point it out.
point it out like which one is there. And sometimes the patient is not also aware if they are having less than 4 days symptoms in a week, or maybe 3 or 5, as Dr. Bikash already said. So, but what I do is whenever there's intermittent symptom, which is predominantly intermittent, then I mention it in my history, because that has got different implications. The treatment guidelines changes because if it's a moderately severe and persistent variant, which is the usual scenario, I usually start with corticosteroids.
So we'll go on that afterwards. So
we need not to differentiate the subtypes.
Okay. So Dr. Urmila, do you have any other opinion on this, or you agree with?
Yeah, I think I agree with all the panelists. This is basically a guideline which is a bit difficult to follow. So I agree with the rest of what the other panelists have said.
Okay. So this question goes to Dr. Rishi. The most of the time, the patient comes to our clinic and they give a symptom suggestive of allergic rhinitis, and we do a ENT examination and prescribe drugs. That is our usual practice because our clinic is so busy. So why it is so important to diagnose and treat allergic rhinitis? Is anything important is there in history taking that we should miss? Is there any importance of systemic evaluation in patient with allergic rhinitis so that we are not missing anything? Because allergic rhinitis are associated with multiple comorbidities. Yeah, Dr. Rishi.
Yeah, Dr. Yogesh. Yeah, regarding the diagnosing allergic rhinitis and the comorbidity associated with it, we need to treat allergic rhinitis. Look, allergic rhinitis was thought to be a very trivial disease in past. Still, it's been thought. In fact, when you have allergic rhinitis, most of the time the patient go for over-the-counter medication. They need not to bother that this is allergic rhinitis or not. They take some over-the-counter medication, and it's not like treating. It's like giving symptomatic relief. So the treatment is a different aspect. Although there is no cure for allergic rhinitis, keeping in mind the immunotherapy which seems to have like disease-modifying results, but still allergic rhinitis doesn't have a cure. What we need to do is this repeated attack has to be of that level that patient doesn't have any effect in the quality of life of the patient. So we need to treat it because it's a very common disease. We all know that in our household, in our community, we might have come across so many patients. And in our OPD patient also, at the end, most of the patients are either from ear or allergic rhinitis if it is from nose. Dr. Urmila statistics already shows that. In our Scott Brown latest edition also, it says like 0.8 to 39, almost 40% of the world population are suffering from allergic rhinitis. It's a common disease, it's a global burden in fact, and it's higher in the pediatric age groups shown by different studies. And regarding the prevalence in Nepal, not authentic study has been done. I come across one study which was done in school-going children via questionnaire. So that reliability of the proper diagnosis is still there. That was done by Sharma et al. In 2018, and it shows 28.2%, which goes with the world trend. So it is a common disease, that's why it needs to be treated and not the symptomatic relief has to be given. Another thing is it's a growing condition. And over the period of like 8 years, some studies have shown that the prevalence has increased from 13 to 19%. Now, why this increase in prevalence is there? And one of the most accepted reason behind that is the hygiene hypothesis, which was postulated by Strachan in 1989. I think most of you know about hygiene hypothesis, even though I like to emphasize on that. There is an inverse relationship between infection and allergy. If the infection goes down, allergy goes up. And vice versa as well. It occurs because whenever we are exposed to microbes, then there is a T helper type 1 cascade that goes on. And if we are exposed to allergen, T helper type 2 cascade goes on. And there's inverse relation, like inhibitory effect of T helper 1 over T helper 2. So when we are getting more hygienic, or we like more sanitation, we are welcoming more allergy, and that can be denied, in fact. And it has got economic burden as well, because with various studies that show like in billions of dollars are expenditure are there because of direct and indirect effect of allergic rhinitis. It's a recurrent problem. Patients do have a lot of difficulties while coming across this disease. It's associated with various other diseases in ENT like rhinosinusitis, otitis media, obstructive sleep apnea syndrome. Polyp is not, in fact, cause of, we all know that allergy is not the cause of polyp, but in polyp cases, allergy is quite commonly found, and in olden days, it was thought to be one of the cause for polyps. Asthma needs a special description, its association with allergic rhinitis that I'll be doing. And on top of that, other allergic phenomena like atopic dermatitis, allergic conjunctivitis, psychiatric condition like anxiety and depressions are also there. Association with asthma is always there because nose and lungs are united together. They are the part of the same unified airway. Nose acts like the air conditioner of lung. It provides the warm, unified, and filter air to the lung. And when they have the inflammation to certain allergens or infection, they do behave in similar way. It's been shown by various studies like 80% of the asthmatic patients do have rhinitis, and more than 1/3 of the patient of allergic rhinitis do have bronchial asthma. So is allergic rhinitis an early manifestation of asthma, or is it the nasal disease? It's a separate disease which goes on to give bronchial asthma in later life? That is not still clear. There is a phenomenon known as allergic mass. We show like this different phases of one's life. Patients develop different phases of different types of allergic disease. Like in infancy, they develop atopic dermatitis, while in middle age group, like in school going age group, they develop allergic rhinitis, while in young adult age group, they have bronchial asthma. And so it has been labeled like allergic rhinitis is the risk factor for bronchial asthma. There has not been a defined correlation between the category that area category that we have already discussed and the prevalence of asthma. However, what has been known is the coexistence of rhinitis with asthma. So if it is not well controlled, your asthma is not going to get well controlled. And so whenever we are examining or taking the history, we always need to screen for asthma as well. And treatment of nose will help for asthma, and treatment of asthma is also helping for allergic rhinitis. So in totality, when we go for history, the Dr. URMILA has already discussed in detail, like we need to rule out rhinitis. First, we need to confirm that this is allergic rhinitis, which is a clinical diagnosis. In fact, we need one or more symptoms out of the 4 symptoms that already have been mentioned. And we need to find if there's any atopy or comorbidity that I've already mentioned. And intermittent or persistent, categorizing them will help for the treatment guideline. And if there's any worse time the patient is having, like in the morning time or any particular season, that again helps for our treatment. Mild, moderate, severe, similarly, it is also required to be elaborated. And ultimately, we try to focus on which allergen could be the culprit.
Thank you, Dr. Rishi. So in a nutshell, what we can tell is that we should at least be able to find if there is any other comorbidities or not. If there is comorbidities, because always the most of the time allergic rhinitis is associated with the comorbidities, so we should be able to find that. And we should be able to counsel our patient that we are not only treating allergic rhinitis, but we are treating comorbidities also, right? So any other opinion from any other panelist?
I think Dr. Rishi has quite elaborately explained why we need to treat allergic rhinitis. So okay, probably we can go ahead. Unless Dr. BIKASH has something else to say.
Yeah, nothing important, but I think Rishi has already elaborated the things in a very well manner, and he has also told about the different literature regarding this. So yes.
Okay, thank you so much. So this question goes to Dr. BIKASH. So there are a lot of expectation from the skill prick test, which is one of the most common, or one of the tests that has to be done in the patient with allergic rhinitis. The patient has a lot of expectation. A lot of the patients, they come to our clinic saying that Doctor to allergy ko test garaidinus ra to mero ke karanle garda feri allergy huncha pata lagaidinus ani mero upachar gardinuस्. They do have a lot of expectation on this test. So my question to Dr. Bikash is, how do you do this test, and what are your experience in its advantage, disadvantage, limitations, and controversy, and what are the problems that you face during the skin prick test?
Yes, thank you, Yogesh. Can you please, yes. Regarding the skin prick test, I want to go straight towards the skin prick test. And first of all, something about the history. Sir Thomas Lewis, he was the first person to start the skin prick test. And this skin prick test is very important because it has got the diagnostic value for this allergic rhinitis, because we can find out the allergens which is responsible for causing allergic rhinitis. Yogesh, can you please move towards the previous slide?
Okay, sorry. Okay.
So how it works is basically a type 1 hypersensitivity reaction, as we all know. And there are certain protocols for allergic tests in our hospital, like I have kept in the slide also in the left side. And for this, we used to ask some patient particulars, and then about the history regarding the symptoms and signs. Then the past history of the anaphylaxis or any urticaria, any disease like thyroid or diabetes. Then about drug history and the family history. And regarding the allergens, till now we are doing the 20 allergens for the testing the allergy skin prick test. And Yogesh, yeah, thank you. And for doing the skin prick test, we use a small lancet to introduce an allergen into the skin. And basically, this is the minimally invasive, inexpensive, and the results are immediately available, because we can get the results within an hour, or you can say within half an hour also. The different studies and mentioned in this curve down also, the sensitivity is also 80 to 97%, and specificity is also 70 to 95%. And the controls is necessary to rule out the dermographism and non-reactivity. And for our study, we use the saline for the negative control and the histamine for the positive control. And there is certain issue, like if the negative control shows a reaction or the positive control shows no reaction, then what? Yogesh, can you please move on to previous slide? So in this case, if the things are there, then one option is we can go to check for the immunoglobulin E level in the blood. That is the one option. And the other option is like, that is the guidelines formed by the Australian Allergy Society. They show that if the negative control shows the reaction, and if it is less than 3 millimeter, but the positive control also shows the reaction, and it is more than 3 millimeter than the negative control showing the reaction. That is, if the negative control showing 2 millimeter and the positive control shows the 5 millimeter reaction, then we can take it into the consideration. Next slide, please. So how we do the skin prick test in our hospital? Procedure is same, like we used to keep the allergen extract on the polar aspect of the forearm, and it should be near about 2 to 3 centimeters from the wrist and antecubital foci. And the allergens has to be kept near about 2 centimeters apart, so that there should not be any cross reaction of the allergens. And we use the lancet for prick, and we used to look at the control and the histamine. After that, then we do the prick test. If everything is okay, then we go for the prick test in the allergens itself. And then we measure the wheel size after 15 to 20 minutes. And for this measuring the wheel size, we have to measure the largest diameter of the wheel. Sometimes the wheels may be irregular. In that case, we have to measure largest diameter and the smallest diameter, and we have to take the mean of the two. Next slide, please, Yogesh. So, what are the advantages of this skin prick test? There are certain advantages, like we can confirm the diagnosis, and with the diagnosis, definitely treatment will be more easier. So we can go for a pharmacological therapy, and since we can identify the exact allergens by doing the skin prick test, so it is helpful in the immunotherapy also. Likewise, we can also reduce the cost of unnecessary tests by identifying the correct diagnosis. Apart from the advantages, there are certain disadvantages also, like there could be adverse reaction, though there is the very rare chance of adverse reaction, but there is chance of anaphylaxis also, and there could be chance of misinterpretation, and there could be the inaccurate results like false positive, or there could be false negative also. So what are the limitations of this skin prick test? There are certain limitations also, like it is very difficulty in the finding out allergens also, because sometimes the patient may have got the allergic to multiple allergens. So it is very difficult to find out which allergens is responsible for causing the allergic rhinitis. So skin prick test is quite difficult. Next is the patient compliance. Since you have to prick on the skin of the patient, so the patient compliance is also under issue. And there could be doubtful results, like positive skin test it may show the atopy, but that doesn't mean that it may reflect the symptoms in or the patient may react to that particular allergens. Next thing is the extensive eczema, dermographism, urticaria, or who are taking medication which interfere with the test results also are the limitation of this skin prick test. And ultimately, contraindication that is relative in pregnancy also. So there are certain controversies regarding the skin prick test also, as there are mentioned in the literature also. I have mentioned, I have kept in the slide also. How young is too young and how old is too old for doing the skin prick test? So different literature shows that the less than 2 years child, it is not good to do the skin prick test because the immune system is not mature. And if you do the skin prick test in the less than 2 years child, and if came out to be negative or positive, then there is a future chance of either development of the allergy is there or not. You can't say. Likewise, if the age is more than 65 years, then the immune system is blunted in the old age people. So the skin prick test may not be quite positive, or it may show some false negative also. So how many allergens should you test? That is also there is a difficult question, and there is controversy also. Different studies shows that it all depends on the patient geography, patient exposure to allergens, and depends on the cross reactivity of allergens also, and how much allergens you can have. That is also the things you should take into account regarding testing of the allergens. So next controversy is the repeat skin test. It is necessary or not necessary. So there is also controversy in this repeat skin test also. The one school of thought who prefer doing the repeat skin test is that if the patient, they said that it is better to do the skin prick test, repeat skin prick test every 1 yearly or maybe in the 3 years. The advantage is that we can see the development of the patient or development of the children. There is a chance of developing the allergy to the new aeroallergens. We can identify by doing the repeat skin test. But the another school of thought is that we should not do the repeat skin test because it is not necessary. Because if there is the development of the allergic symptom, then you have to go for pharmacotherapy. You don't have any other option. So there are the controversies regarding this skin prick test also. Yeah, thank you, I guess.
Okay, thank you. So one of the problems that what we face in teaching hospital while doing the skin prick test is that we don't know what are the local allergens available, means what are the local allergens causing the allergy. And normally other thing that what we face is that we don't get a reagent so easily. It is not commercially available in the market. So we have to get it through other means from India, and we don't know those pollens or those allergens, they prevail in our community or not.
Yes, I agree.
So do you also face similar type of problems?
Yeah, definitely, Yogesh, you are right. Because the allergens which are available in India, it doesn't mean that it should be the same allergens which is this in Nepal also. Yeah, so you have to agree.
So another thing that I agree is that we do only hardly 10 to 20 allergens. We do a skin prick test. So there are number of the allergens in the environment. So I think one of the limitations is that too. Any other panelists, do we have any other opinion on that?
Yeah, I think I want to add one more thing. Basically, there are many aeroallergens, basically pollen aeroallergens, which we're not aware. I mean, we don't have a pollen calendar here in Nepal, so we don't know what are prevalent in this area. We're just using the allergens which we think are useful here, but we're not too sure which, especially for the pollens. It's difficult unless we have a pollen calendar. But for the house dust mite, I think it's prevalent everywhere. So probably that shouldn't be a problem with house dust mites. I want to ask a few questions to, ask a few questions to Dr. BIKASH. Normally, so you would include house dust mite. Do you include food allergens also in your panel of tests or skin prick tests?
Yeah, I have already shown. Yogesh, can you please go?
Yeah, sure. I can show this. I can show, yeah.
Yeah, we have this list of these allergens. We use, we do this skin prick test.
So I think you get reagent from Germany, right?
Yeah. We have this good collaboration with this German Allergy Society. So they do provide us these allergens.
So and sometimes what I wonder is that the same allergens that a dog or cat or rat in Germany they do have, do our dog, cat or rat they have or not?
you are right, because by doing this skin prick test, I will come in this sublingual
Okay.
immunotherapy case.
Okay, sure.
Yeah, though, yes, Yogesh, I will come later.
Okay, okay. So we move on, right?
Yeah.
Okay, so we move on. So so this
I'll
question,
also like to highlight few points.
sure, please.
Like when I started doing skin prick test in Nepal a few years back, I started doing from India, and there was a problem with the cold chain as well, because when I purchase it has to be transferred to the whole every time through the refrigerator or in the ice block.
Yeah,
Then I didn't have any idea, because we didn't have any particular allergens that can be done. So when I asked the company, they give me a list of like 300, 400 allergens. Which one do you want? I brought like 150 to 200 and don't know which one to start with. Then I started doing, and then which were common in most of the patients, then I repeated doing in the other years. And in food allergens also, I got few cases in wheat and peanut, which I remember so far.
So I can share the interesting things that study that we did in a teaching hospital, and we did two study, in one in 100 patient, I think 126 patient, other than 80 patient, and in 85% of the cases they were polyallergens, and in 15% of the cases they were monoallergens only.
Yeah, almost.
And the most common was house dust mite or other variety of the mites.
Yeah, regarding the food that I was talking about, otherwise the house dust mite is definitely the commonest cause of allergen in our society. In my study, it was like 80 to 85% people have house dust mite allergy.
Okay.
Yeah, I think I want to add one more thing. For food allergens, I think the reagents that we get are not too good, because the allergenicity of the allergen is dead by the time it reaches to you. So I think you can do a prick-to-prick test. I think that will be more feasible or more applicable even in our part of the world. You can just take whatever food the patient is allergic to and just do a prick-on-prick test. Yeah.
Dr. URMILA, what about the? I want to ask one question. What about this reaction, that is anaphylaxis, something like that, with doing the prick-to-prick test? Is there any chance?
The risk of anaphylaxis for any kind of, even for skin prick test, is there, but I don't think it's been recorded, unless it's an intradermal. If it's an intradermal, then you'd more anaphylaxis. But for this prick-to-prick test or skin prick test, there's this very minimal amount of allergen that you'll be introducing, and the risk of anaphylaxis is very rare. But having said that, you should always be ready to handle anaphylaxis.
Yeah.
So we should always be prepared to deal with anaphylaxis while doing skin prick.
One point that Dr. Bikash has already mentioned and like to emphasize to all the participants is that skin prick test positive doesn't mean that you're having disease. It just shows that the patient is sensitized toward that allergen. So just detection of sensitization without any clinical history, relevant clinical history, is not going to make your diagnosis of allergic rhinitis.
Yeah.
It does help for your diagnosis and your further guide for your treatment.
So next question is that we normally start with this. We know if any patient comes with symptoms of the allergic rhinitis, then we send total serum IgE and start to work up. So, but this total serum IgE is usually elevated in another allergic condition or non-allergic condition also, like in.
But there are certain conditions where we are not able to do the skin prick test, right? Like in case of patient using some kind of medications. There is also contraindicated to doing the skin prick test, like in case of dermatographism or something like that. In that case, yes, we may need to go for this serum-specific immunoglobulin antibody test. So AOHNS guidelines also recommend that we can also go for the serum-specific immunoglobulin antibody test if required or if necessary. Yes.
So Dr. Rishi?
One thing is that the RAST is not used nowadays. This is a radioallergosorbent test.
Yeah.
What they usually do is immunoassay test, which is ELISA basically used. Rather than using the radioallergen.
Yes.
Most of the lab they are using this. And as both of the other panelists have mentioned, like you have the choice of SPT and RAST. Both of them have almost similar positive predictive value, although SPT has slightly better positive predictive value. But you can go in either of these, and it depends on the clinical judgment of the treating physician and the preference of the patient who is being treated, in fact, because if the patient doesn't want to be pricked and want a report of different thing in just with the one sample, don't want to waste time like 1 hour there in skin treatments, you can go for RAS test also. For RAS, you don't need expertise, you just send them to lab and they will do it with the serum. For SPT, you need some expertise, you need to have that set of allergens with you. So both of them have certain advantages, certain disadvantages. So I don't really feel any difference if you're going for RAS or with SPT.
Okay, thank you. So next question is that, Dr. Urmila, we know this allergic rhinitis is a chronic disease. So how important is the counseling in the treatment of allergic rhinitis, and how do you counsel the patient to prepare for the treatment?
Yeah, so as you said, it's a chronic disease, and it's, the symptoms are not going to go away in a short period of time. And we have to be aware that the patients which are affected are in the productive age group. So their quality of life is definitely being affected by allergic rhinitis if they've come to you for medical treatment. So counseling is an important aspect of any management of any conditions. So and it's equally important in allergic rhinitis as well. As Dr. Rishi has already pointed out that it's a multi-organ system involvement by the allergy. So it would definitely need a multi-speciality treatment. So the counseling should be such that the patient would probably need a referral from the eye team, from the respiratory team, or even from the dermatology team. So treating one condition would definitely have a positive impact on the other side, other part of the disease. There would be less flaring up. So that has to be instilled in the patient's mind. And there are certain myths regarding triggers. Like many patients come to you and say that taking cold food would trigger allergic rhinitis. And that's actually a myth. Probably what they have is a vasomotor rhinitis, or probably just a physical rhinitis. But there are certain foods, mostly if they are containing molds, in case of like cheese, wine. In those cases, probably the food can trigger allergic rhinitis, but if they're not allergic to food, the patient may have a concept that they are allergic to food. Food allergy is a different entity which has to be treated differently. And with regards to medication, I think what I've come across in my practice is patients, since they have to be on medication on a long term, they do not adhere to the medication. Especially the way they are taking, the techniques are not right. So they come to you and say, oh, the symptoms are still the same in spite of using nasal sprays and all that. But when you ask them how they have taken the medication, most of the times they are not taking it correctly. So that also has to be incorporated in the counseling as to how it should be done, more so for the nasal sprays and also for the nasal drops. And adhering to the sticking to the medication protocols that they have been advised is important for the symptom control, because we're not offering them a cure unless we're doing an immunotherapy. These medications are just for a symptom cure. And the side effects, especially for nasal sprays, because epistaxis is quite common if they are not doing it proper, if they are not using the nasal sprays properly. That has to be also explained, otherwise they would probably freak out. And patients a lot of patients do come to you with topical decongestant overuse, which is not good for the patient, so they may end up having rhinitis medicamentosa. So use of decongestant should be discouraged. Next slide, please. So in our clinic, in our hospital, so we have a leaflet for the patient advising on to how to properly use the nasal sprays and nasal drops. So pictorial patient leaflets would definitely help the patient to adhere to proper medical application technique. Next slide, please. And counseling also would involve combine multiple measures, then there is a definite decrease in the level of allergen that you're exposed to, and also there is improvement in the nasal symptoms. So probably if it is possible, it's easier said than done. If the patient can adhere to multiple allergen avoidance technique, then the symptoms may improve. So that can also be told to the patient during the counseling session. So and counseling session is very important, like for any other diseases. Yeah.
Of the patient, what they do is that they come to us and say, Dr. Sahab, यहाँ पनि गयो औषधि खा, खानुसम्म ठिक भयो, खाएपछि फेरि बल्झ्यो रोग. So I think the counseling part is very important before we start with our treatment. So we know that in the management of the allergic rhinitis, the treatment, it revolves around the avoidance of allergy, patient education, pharmacotherapy, and immunotherapy. So these questions I like to ask Dr. Rishi, how do you? So when you treat a young patient with allergic rhinitis, do you focus on pharmacotherapy, or do you consider the preventive measure also equally important? And if that is important, so what are the things that you like to tell to your patient?
Yeah, Dr. Yogesh, you've already mentioned our different treatment options that we have. The one thing that we can do is education and counseling, that Dr. Urmila has already mentioned. Pharmacotherapy is the usual thing out of which everything revolves around. When you give medications, then you need to monitor after certain time, not immediate, not after 2 or 3 days. I'm talking about the maintenance phase, okay? Not for the immediate relief. So monitoring of therapy will be done usually after 2 to 4 weeks. And if the patient doesn't have any significant nasal complaint and doesn't interfere with the daily activities, then you label them as control. In that scenario, you can maintain the same drop, or you can step down in the coming month. And if the patient doesn't have relief of the symptoms, still having some sort of complaint, then you go for a step-up approach as per what the symptoms are predominant of the patient. And still with the combination of medication, the patient is not having relief, then you may need to revise your diagnosis as well. Along with the pharmacotherapy and counseling, environmental control measures has its own beautiful role, in fact. And beside that, immunotherapy and surgical measures that we'll probably be discussing. So in pharmacotherapy, most of the things revolves around intranasal corticosteroids. Let's move to the another slide. Regarding the counseling, Dr. Urmila has mentioned some of the things that I like to emphasize is really crucial. You need to spend some time educating the patient what the disease is. The patient should know the chronicity of the disease. They have to live with this, how to adapt their treatment as per their symptoms. They can learn by themselves. It's not a very difficult thing to do, I suppose. And over the time, the remission as well. Like one study done in 2006 shows that 23% of the patient after like 8 years, they have improvement in the symptoms. So over the course of time, the disease is going to decrease, and also proved by in less severe allergic rhinitis and less prevalence in old age. Next slide. The AOHNS clinical practice guideline advise the environmental factors. They state like they may advise. It's not recommended, fully recommended. It's like on the equilibrium of benefit and harm. They have advice for avoidance of allergens. Next slide. So, but in our layman's thinking, or even as a doctor, we think like this logically, the thing that is causing harm, if you avoid that, why you are not getting the benefit of symptom? But it is not always like that. As Dr. Urmila has already said, we have a lot of allergens to deal with. Like there can be indoor allergens like house dust mite, which is the #1 all over the world, and whatever study has been done in Nepal also shows house dust mite is the #1 cause of allergic rhinitis in Nepal. Besides that, cat, dog, cockroaches, in fact, that was out of the top 5 in one of the studies that I did in Nepal. There can be outdoor allergens, which are basically airborne pollens, which vary throughout the year, especially in Western countries, in Europe and North America. They have a precise, like in tree pollen will be there in spring, and there will be grass pollen in summer. They have a very defined pollen calendar, but we don't have that pollen calendar in Nepal. If that had been there, then we could have a chronological correlation of our symptoms with the pollen that could be probable in our scenario, or maybe that location, the geographic location, and patient can apply that avoidance measure. This slide already shown by Dr. URMILA that even though you have decreased reduction of allergen level, you don't get that symptoms. It has been shown by some studies like Teros study in 2003. Even though there's 30% reduction in the house dust mite allergen, you don't get that clinical benefit. Why? Maybe the methods are not totally able to eradicate the allergens. A small amount of allergen is still able to cause you the symptoms, or it may not be feasible, or in long duration the patient is fed up, doesn't get aware of that avoidance nature. Next slide, please. Some of them may be impractical, difficult to implement, and not effective when they are used alone. If a combination, then you may be able to run away from it. But our community is different. Our community is very happy to follow these environmental measures. Like whenever you ask, like take this medication, they'll ask first thing, what are the things, doctor, I need to barne? That's the first question they need to ask. They will ask you. And they may be dying of malnutrition, but they won't think of barne. So in barne, we don't have much. Like whatever you can, they can try. You can say the cat is causing you allergen. Now get avoid of that cat. How you can do it? So there may be food allergens, but our community is more focused on food allergy. But food allergy is usually not a culprit of isolated nasal symptoms, already been mentioned by Dr. URMILA. But there are some foods that has been mentioned, but it's not so well defined. There are different methods. In fact, these methods are, the patients are more aware and they will practically more do it rather than you tell them. But some of the things that I need to mention is, like for house dust mite, we can wash our bedding, preferably with warm water. That should be around 55 to 60 degrees to kill the mite, not with the cold water. You can apply impermeable coverings. That will also help to reduce some bit of allergen. Use of insecticide has got allergen reduction as well as symptomatic benefit, has been shown by some study. Putting the our mattresses in sunlight also helps. Next slide, please. Pollen avoidance, you need to close your windows in the pollen season. But in our country, in tropical environment like ours, like all throughout the year, there's some sort of flora growing and pollens are always there in our air. So consider wearing a mask, not only for corona, also for your allergic rhinitis when you go outside. And as far as possible, try to minimize your time spent outdoors. For mold allergen, you need to decrease your humidity, because if the humidity is increasing, there's more chance of molds to grow in your environment. And hard flooring, avoiding any cracks in the room will help for mold allergen as well. Pet allergen, best thing is remove the pet. There can be neighbor's pet, you may not be able to get rid of it. Apply other measures like exclude them from bedrooms or wash them properly twice in a week, something like that. May help a bit, but it's not like be defined, because even the guideline says it may help only. For cockroaches, you can use lots of things like insecticidal bait, or you can seal the cracks or enclose your food so that they don't come. So these are the measures that you can do as environmental measures. Yeah.
I'd like to add one thing. You have exhaustively said that the environmental control. I think why it doesn't work is it's easy to say, difficult to follow. Like it's difficult to follow social distancing, I think.
Yeah, because it is just like one of the most difficult things to reduce weight. In every treatment modalities, one of the treatment is you reduce your weight, but it is very difficult to do it.
Yeah.
Same thing. So one question to all, one word question. Most of the patient, they do come to us and say, Doctor Sahab, yo doodh dahi khara mero pinas ta yati dherai badeko cha. मैले दूध दही मोही नखाएको दुख जुग भइसक्यो. So what do you say to them?
I think doodh allergy is food allergy, and it's more rampant in children. And normally they tend to, it's cow milk to be precise, and they outgrow it like in 6 to 8 years.
No, in this type of the patient, in allergic rhinitis, adult patient, when they come to you and say, Doctor Sahab, मैले दूध दही खान मिल्छ कि मिल्दैन, म त पिनास छ, मलाई वैद्यले त दूध दही नखानु भनेको तपाईँ के भन्नुहुन्छ?
त्यही त नि, अब दूधको एलर्जी हुँदैन भन्नु पर्यो.
Yes, okay, Rishi. So what do you say?
So first thing, you can go for a SPT or immunoassay test. If milk comes or curd, something like that, you can avoid it. There will be some evidence for us to show, like your milk was done, it was negative, if you really want to counsel. Now regarding allergic rhinitis or any some sort of rhinosinusitis and curd or milk product, why it has some sort of scientific background, what I think. It affects the mucus flow, what has been shown by some of the studies. So if you take more amount of dairy product, it may affect your accumulation of mucus in your sinuses and may affect. So that's
Okay, so
that's what they are. That's on which ground they are practicing avoiding
Okay.
the milk and dairy products.
So Dr. Bikas, what do you have to say something on this?
Yeah, I want to say that यदि कुनै पेसेन्ट आउँछ like you said that दुध दही खानु हुन्छ कि हुँदैन भनेर या एलर्जी हुन्छ भनेर I used to say them that यदि दुध दही खाएर यस्तो सिम्पटम्सहरु चाहिँ एकदम एग्राभेट हुन्छ त्यस्तो प्रब्लम हुन्छ भने then better to avoid it, otherwise you can take it. Simple answer.
Yes. So you do a provocation test in other way.
Yeah.
Right? But we need to be cautious, like avoiding milk, and you land up with osteoporosis and calcium deficiency. Your bones get weakened. That has to be also to be thought in our scenario, right?
Yeah. Okay. So we know because we are running out of time right now. It's already 7. So we know the medical management run like this: saline nasal douching, antihistaminic, decongestant, muscle stabilizer, anticholinergic, intranasal corticosteroids, anti-leukotrienes, and immunotherapy. So, and we know this allogram how it goes up, step down. I'd like to ask Dr. Bikas, how effective oral second generation antihistamine that we normally start with is effective in the treatment of allergic rhinitis, and which molecule do you like to choose and why, and how long do you go, what are the side effects or precautions that you explain to the patient?
I generally go for the antihistamine, second generation antihistamine for treatment of the allergic rhinitis. If the patient has got symptoms and then the intermittent symptom or maybe persistent symptoms, for that I prefer this levocetirizine mainly.
Okay.
And this levocetirizine is I used to give them 5 mg POHS for nearly about 2 weeks, and then I usually titrate the things.
Okay.
And I used to tell them to come for a follow-up. If the symptom is improving, then I used to maintain that dose for next 2 or 3 weeks. Then again tell the patient to come for the follow-up. If he or she is improving, then it's okay. But if he or she is not improving, then I will step up this treatment strategy.
Okay. So we'll come on that. So Dr. Rishi, we have one of the other modalities that is monotherapy that is commonly used is intranasal corticosteroids. And commonly available intranasal corticosteroids in the markets are, which are mentioned here. So which molecule normally do you choose it? How do you choose it? And normally what are the dose, duration, and side effect that you explain to the patient?
Yeah, usually this is the drug, this is the preferred monotherapy, in fact, for allergic rhinitis. This is usually the first selection. And I usually go for fluticasone or mometasone. I usually don't use meclonidazole because it's also not useful, it's not indicated in children, and better to use for fluticasone and mometasone, for which lots of study has been done and it's safe and efficacious. Only reason that may not be using sometime if the patient has the financial constraint, because antihistaminic is quite cheaper and this costs like 300, 400 for like 15-20 days. So they may not be able to afford that. So on that grounds, I may be going for other one. Otherwise, my first choice usually will be intranasal corticosteroids.
How do you go up?
With 2 puff twice a day. Regarding the severity, like usually in most of the patients, I start with 2 puff twice a day. And the proper way of doing what Dr. URMILA has mentioned has to be counseled to the patient beforehand. And then when the patient has control of the symptom, then I either maintain it for 1 or 2 months and then taper it down like 2 puff HS at the night time, and then every other day, then once weekly, and then that's how it is taken off. Sometimes in few patients, like if the patient has typical intermittent symptom, like they say only in Fagun Maina I have the symptoms, then you take at the end of March intranasal corticosteroid, take throughout the Fagun, you don't have the symptoms. That may be some sort of pollen aggravated allergic rhinitis. In that scenario also I use intranasal corticosteroid.
Okay, thank you. So doctor, this question goes to Dr. URMILA. How effective is oral leukotrienes agonist, that is montelukast, as a monotherapy for a treatment? And should we use it or not? Or beside oral antihistaminic and intranasal corticosteroids, do we use any other agent as a monotherapy? If yes, which one?
Okay, so oral leukotriene receptor antagonist as a monotherapy has not been advised in many of the studies, and more so since we're talking about AOHNS quite frequently. So that guideline also states against it. However, there's one condition: when the patient has associated asthma, then in that case, this would definitely help. But in just a simple allergic rhinitis, I think other modality like antihistamine, which is cheaper than as compared to this drug, would be better used than this. And other monotherapy, I think we don't have much other options. Unless we had options like intranasal antihistamines like azilastine, that probably would be good, but we don't have an option, so we just have to probably stick with antihistamine or intranasal corticosteroids whenever, depending upon what the patient's symptoms are. Yeah.
So going back to your Montelukast, it's like if the patient is having allergic rhinitis and asthma, so is a Montelukast used as a monotherapy or in combination?
No, it can be used as a monotherapy in that context.
Means in the patient with allergic rhinitis and asthma, so you'll be only using Montelukast.
Yes. If there is an exacerbation of the bronchial asthma, then probably the patient would be needing inhalers as well.
Okay.
This is more so indicated when there is additional, exercise-induced exacerbation of asthma. So that's what we mentioned.
Okay. I have a slightly different view than Dr. URMILA here. Like if the patient is having bronchial asthma, why not to go with intranasal corticosteroid? That also helps a bit of asthma, because monotherapy of LRTA, this is usually not recommended. Though it is helpful in asthma, I agree. But if you want just one medication,
I think initially the patient with can be given treated with intranasal corticosteroids, but later on when the patient is better, then we can continue Montelukast as a monotherapy for a few months, so that which will benefit the patient. Okay, let's move. Now comes a cocktail. Every time the cocktail is very good. And in allergic rhinitis also we use a cocktail. So what combinations are normally we used? And so I like to go in specific question. Does addition of oral antihistaminic to intranasal corticosteroids help in the patient when there is a persistent symptoms despite use of intranasal corticosteroids? Meaning that if the patient is using intranasal corticosteroids and his symptoms is not improving, does oral antihistaminic helps in that scenario, Dr. URMILA?
In general condition, it has been mentioned adding antihistamine to intranasal corticosteroids does not have an additional advantage. But and more so if it is in a perennial allergic rhinitis. But the area guidelines does have a guided, a limited evidence on saying that it might probably have a good result in case of seasonal allergic rhinitis. But overall, it doesn't have an additional advantage of adding oral antihistamine to intranasal corticosteroids. And we do have other options, so probably we'll have to go for other options as well.
So my question to Dr. BIKASH, so are we practicing in a wrong way then, since long?
Well,
most of the time we use oral antihistaminic and intranasal corticosteroids.
Yes, in our setup also we use the oral antihistaminic plus intranasal corticosteroid. But if we go to the literature and if we follow the AOHNS guidelines, then they mention that there is no extra benefit by using the oral antihistaminic with the intranasal corticosteroid. But we have to think about that, because this is also the study done in the West. This is not the study done in Nepal. So maybe this is the research topic also. We can do in the Nepal also, and we can also look at our patient also, because physiology may be different in the Western people and the Nepal people.
True, true. Yeah, Dr. Rishi, you want to add something?
Oral antihistaminic, because we know that intranasal corticosteroid takes certain days to act. Like in fact, we are using intranasal corticosteroid only. What I usually do and what I think is for the guideline as well. But it needs like 5-6 days to work. And whatever the 5-6 days of patients to get used from. So oral antihistaminic is the answer. So for 5-7 days or maybe to the maximum 14 days you can give. And by that time intranasal corticosteroid will have its full efficacy. Then you can continue with the intranasal corticosteroid. And that applies with the guideline as well and our practicing.
So what I agree with Dr. URMILA is that normally treatment efficacy we only evaluate after 2 to 4 weeks. We don't start with the day one. if we give intranasal corticosteroids today, we don't re-evaluate the patient after 4 days. We evaluate the patient only after 2 to 4 weeks. That is what is the guidelines, right? So means if we start intranasal corticosteroids today, means the intranasal corticosteroid will be working after the 7 days. So we are not assessing within 7 days. So I think the symptomology that the patient is having should be understood. After using intranasal corticosteroids, is everything is better, but nasal obstruction is not being better. So then we may think that it is not working. So we may think of another. If itching symptoms is much more, so then in that sense, we may add intranasal oral antihistaminic and may help the patient. So I think overall, we don't say that this is not better. We say that which specific symptoms is not better.
Yeah, you are right.
Yeah.
You are right.
I think with intranasal corticosteroids, I mean, everybody is aware that it deals with all the symptoms.
Yeah.
All the symptoms. And for like montelukast and mometasone and fluticasone that we normally use, it would usually work within 12 hours. So the patient probably will not get the 100% result out of it, but slowly it's going to help the patient. And I think since the patient has been having the problem for so long, they probably can wait for a bit longer for the medication to act if we counsel them properly.
Yeah, but in the treatment efficacy, if we see the chart that is provided by YOGESH, everything is well controlled by the intranasal corticosteroid except itching, weight, and antihistaminic works better.
Mm-hmm.
Yeah, true.
So, okay, let's move. Is this combination helpful? Oral antihistaminic and montelukast. What do you think? We don't have available combination in market, but we have a separate capsules. Dr. RISHI.
This has been used, and some of the studies have shown that it has some benefit especially in the seasonal type of allergic rhinitis. Mm-hmm. But usually what happens, like leukotriene receptor antagonist is not started as a monotherapy. So probably in this scenario, in oral antihistaminic, the leukotriene receptor antagonist has been added. So in that condition, when antihistamine is not giving you the good result, why not to switch to intranasal corticosteroid and not add 2 medications, but switch to another one, and then continue with intranasal corticosteroid. Otherwise, even if you try with this has been shown with some studies, like it helps, but not as much as the corticosteroid does.
Yeah, because most of the time we are talking about the additional options because patient may not be compliant to intranasal corticosteroids always. So those patients who are not compliant to intranasal corticosteroids, maybe of this therapy, if they have coexisting asthma also. So Dr. BIKASH, do you want to add something on this?
No, not exactly, but whatever you said and RISHI mentioned, this we can add the whole antihistaminic along with the leukotriene receptor antagonist, especially in case of allergic rhinitis with the, as you mentioned, in case of this what is that, asthma. Yeah, we can use that. Yes.
Okay, thank you. So let's move to another, because we are interesting thing is coming. So so what about this intranasal corticosteroids and leukotriene antagonist? I think RISHI has already answered this. I think Dr. RISHI has already answered this. So let's go to this. How many of us has used all 3? Intranasal corticosteroids, oral antihistaminic, and montelukast? Dr. URMILA.
I think regarding the cocktail not working as good as it's supposed to be has already been discussed. So I think we're going to adding one more thing on top of what you've been already using. To me, I think it's not necessary.
Okay.
I think I would stick to intranasal steroids and make sure that the patient is doing it correctly, because most of the times I find they're just sniffing the medicine, they're not taking it properly. So I would avoid this combination because it will be an additional economic burden to the patient without additional benefit. Yeah.
Okay.
But if the symptoms are not controlled, then in that scenario, maybe in the process of step up, we may have to combine all these medications as well. Because when you are combining all 3 medications, it looks as if the patient really needs immunotherapy here. But if the immunotherapy is not available, as in our usual setup, then we can go with this, because patient symptom control is the prime concern for us. So if 2 medications is not giving the result, why not to go with another one as well?
So it may be that sometimes, yeah. So Dr. BIKASH was saying something.
Yeah, I also agree with RISHI, because if the symptoms are, patient are suffering from the very symptoms, and if the medicine with intranasal steroid or the oral antihistaminic not controlling the symptoms, then why not we go for the 3 medications? As Rishi correctly said, there is chance that the patient may require the immunotherapy, but the immunotherapy is not available in everywhere. So better to go for or explore this option also. Why not?
Okay. So it means that we start with the 3, and after symptoms are controlled, we come down to 2, then finally come down to the 1. So we are going to step up, we are going to step down. So
which is the intranasal steroids that you're using? Probably one formulation may not be working, and the other formulation would be better to that patient.
Yeah, sometimes what I find is that the intranasal corticosteroid, though the patient is using it, it is not working. So it was working to the patient in last 15 days, but last 5 days it is not working. So normally what is that intranasal corticosteroids? It has got active molecule in that, and it has got propellant also. So initially, if that if that vial contains an active molecule and a propellant, so that if it is written it has got 50 puffs, 50 meter dose, means you can spray 50-meter dose of active drugs, but after that also something will come out. But that is not drugs, that is propellant, and that propellant are allergic to the patient. So we should always tell to the patient, you have to stick to the drug on the regular basis, so that he will know after how many days there is no drugs in his container. So that is also thing that has to be considered.
Practical things that you have to look for. Yeah.
So when we consider this intranasal corticosteroids and in drops like xylometazolone intranasal drops, Dr. DC?
Yeah, we can use this. Like if intranasal corticosteroid is, it depends on which symptoms the patient is predominantly having. If the patient is having blockage, despite using intranasal corticosteroid, then obviously intranasal oxymetazoline is the drug that can be added. Then if the patient is having a symptom of itching and sneezing, then adding up oxymetazoline is not going to help there.
Okay. So it depends, means if the patient is having the obstruction and sneezing as a principal symptoms, so initially we give a drops for 4 to 5 days. Then after 15 minutes, then we'll use intranasal this spray. Then after 5 days, he's only using the intranasal spray, right?
Do not be using this for a long time, as we all know that rhinitis medicamentosa is a potential.
So most of the drug, over-the-counter drugs, that is anti-cold medication, most of the patient they take it. Doctor म त rhinitis खाएर sinus खाउँछ अलिअलि हाच्याउँछ खाइदिन्छु ठीक हुन्छ अनि फेरि छोड्यो फेरि बल्झिन्छ. So what is your take on that, Dr. Bikash?
Well, this is a quite interesting question, because in our setup also people with the allergic rhinitis also came with this kind of things, like you have mentioned correctly. Doctor साहब मलाई त हाच्छु आइरहेको थियो, आँखा पनि चिलाइरहेको थियो, नाकबाट पानी बगिरहेको थियो. I have taken this rhinitis and decol, and now I got somehow improved, but एक हप्तापछि फेरि यस्तै भइरहेछ doctor साहब, symptom like that. So I think if the diagnosis is clear-cut allergic rhinitis, then it's better to go for the whatever treatment we have mentioned. That is the good option. But in rhinitis sinus also there is the chlorpheniramine also. So maybe that may be the cause of this is the beneficial for the patient. And there is also I think phenyl. There is one component in rhinitis or sinus.
You have decongestant and anti combination. Yeah,
decongestant is also there. Because of that, maybe his or her this nasal problem, this nasal obstruction may get improved. So better to follow this principle of using the intranasal corticosteroid and whatever the things in the allergic rhinitis guidelines, rather than using this rhinitis sinus or decol like this. I think so.
To me, I mean one of the agent that we use for allergic rhinitis is decongestant as well. More so rather than oral, it's the drops, and also the antihistamine. So probably it does work as an anti-allergy drug, but for a short period of time, and you cannot continue taking this like you can do for like other antihistamine or intranasal steroids. Probably short period of time, if they have an acute symptom, this probably helps even for allergic rhinitis.
I slightly differ with Dr. URMILA and Dr. Bikash here, because rhinitis and sinus they have got 3 drug composition. There is paracetamol, which is of no use in allergic rhinitis because they are not having fever or body ache, anything like that. So why to take unnecessary medication there? Alpha agonist that we have there, like phenylephrine, is a systemic drug. It will definitely decrease your congestion, but on the same time, it also affects like increased blood pressure with all sympathomimetic activities. So a patient with hypertension, diabetic, already had a stroke, you should not be allowed them to take these medications. The only thing that could have worked there is the antihistaminic, which is also in limited amount. So why not to take a good proper dosage of an antihistaminic, or you can add up one oxymetazoline there, and the result is almost like the same. So why you take unnecessary medications for the?
So the conclusion is that we should discourage the patient, saying that they are much more side effect than the benefit, and you should be going in the particular type of the drugs which has got less side effect and more benefit to you.
But what I mean to say is, I mean, you should not promote this medication for anti-allergy, but if they've already taken it, I mean, they would definitely get some symptoms because of the antihistamine and the decongestant part that there is, but it's not a long-term medication. And as Dr. Rishi said, it has a lot of side effects, and it's better, we have a better option, so probably we go for the better options.
I also this thing agree with the Rishi. If patient has got allergic rhinitis and the symptom and sign is quite this thing, so we have to go for these guidelines regarding treatment of allergic rhinitis, not taking this rhinitis or depot like things. Yeah.
Okay. So in short, because we are running out of time right now, I think how do we manage acute exacerbation of the allergic rhinitis? Despite using oral corticosteroids, do we use any other methods on top of those medications, intranasal corticosteroid, antihistaminic, or xylometallogene? We sometimes add oral corticosteroids. Do we have any other options than that for short course?
I think oral steroids would. I mean, you have always had. Do we have any other options? Unless we have intranasal antihistamine.
Yes.
So we do give a short course of the oral steroids. Then after that we continue on our own medications, that is the intranasal corticosteroids, antihistaminic, and if needed, montelukast. Okay.
Or probably add nasal drops, decongestant nasal drops.
Drops according to the symptoms.
Because we need to try to see which symptom is predominant. Accordingly, we can give it. Like if the blockage is the problem, then give decongestant, in fact.
So a lot of the patient, they do come as डाक्टर साहब तपाईको औषधि खाए ठीक हुन्छ छोडो बल दिन्छ अर्कोको जान्छ. So can we try Ayurveda or alternative medications for this? If they ask us, do we have any experience or literature done, does they help or not?
Or
Okay, there is a study done by British Society of Allergy and Clinical Immunology. They don't have that level of evidence to support for the recommending these alternative medication, in fact. But if the patient wants this treatment, we can tell them that you can go ahead with this. But still, as we practice allopathic medication and with evidence-based medicine, still not proved that this is going to really help. But if the patient is willing for this, just to need to make sure that patient is not doing any harm from using those medication or alternative things. Otherwise, they can go ahead with this.
Okay. Any other opinion?
I also agree on, like, some people advise yoga. There are certain yogi postures that you can follow.
Yoga is there, but this is alternative and Ayurvedic medications. I'm only talking about the medications. Okay. Yoga is so we're coming to that.
Okay. But I thought alternative medicine, the yoga and all that also falls in.
Okay. So yeah, definitely yoga. So any take on inferior turbinate reduction and septoplasty, or one of those while treating the patient with allergic rhinitis, Dr. Bikash?
Yeah, yes, definitely. Because if the inferior turbinate is hypertrophied and if causing the nasal obstruction, and if we can't use the spray properly, then in that case, and symptom is also very much worse in that case, like nasal obstruction, in that case, we can go for the inferior turbinate reduction. And the benefit of inferior turbinate reduction is that the patient may have the feeling of the nasal patency, one, and the second is the drugs can be delivered easily, so the dose of drugs can be reduced. Okay. But there are certain disadvantages of doing the inferior turbinate reduction, like this is the surgery, so the surgery has got complication also, and there may be chance of atopic rhinitis also. So we have to think these things into account also. Yeah.
Any other opinion?
Yeah, I think I agree to Dr. Bikash. These surgeries are basically to help your medication reach into the nose. I mean, some patients do have like very gross DNS, and the medication will not reach where it's supposed to reach. And the other thing we have to clearly mention to the patient is that the allergic symptoms is not going to go away. It's just the nasal obstruction that is going to be relieved if you use the nasal medications, nasal sprays properly. But so people, I mean, patient may think that doing a surgery would completely take away all the symptoms. So the counseling part regarding the need for persistent medication use even after surgery is very important out here. And even for inflammatory reduction, probably would not be the first thing that you do unless you see that the inflammatory is not reacting or responding to the medication, intranasal corticosteroids. So in the outpatient, if you put a decongestant, and if the turbinate doesn't seem to be shrinking, probably there's fibrosis of the turbinate, which is not responding to the nasal steroids. Yeah.
Okay. Okay. So we move to another questions. So this goes to Dr. Bikash. So immunotherapy is such an agent which modifies the natural process of the disease. So how do you do it, and what is your experience? And is the immunotherapy final answer in the patient with allergic rhinitis in our setup? What are the limitations of immunotherapy?
Yeah, thank you, Yogesh. And yes, immunotherapy, yes, we are doing in Dhulikhel Hospital, and we did it since 2015-16. And our study by the skin prick test shows that the house dust mite is the most commonest allergens in our setup in Dhulikhel Hospital. So we usually use the immunotherapy for, and especially sublingual immunotherapy for the house dust mite. And for this, things we consider before going for the immunotherapy is like patient compliance must be there. If there is no compliance, then there is no use of doing the immunotherapy. And till now, we are doing immunotherapy only for adult patients. And there is also some evidence regarding the this allergen, like clearly positive skin prick test to house dust mite. Next is the next is the positive house dust mite E, that is the Kota Bella I have mentioned, and there is also sometimes required to go for a positive nasal provocation test to USDM, that is house dust mite. And before doing this, the patient or the allergic patient must have gone for the encasing with their pillows or all that things, and the patient must have undergone the medical treatment. And if they not get benefit from all these things, then we go for the sublingual immunotherapy. Next slide, please. So regarding the dosing of the immunotherapy, we generally use the European guidelines for giving this sublingual immunotherapy. And for day 1, we use the 300 international unit at hospital. It's a tablet. And we used to keep the patient for near about 4 to 5 hours in hospital during the immunotherapy, because we want to see whether there is any reaction. Like maybe there is remote chance, that is 0.056% literature, but there is chance also. So we have to keep the patient in the observation during the day 1 to see whether there is any reaction or not. If there is no reaction, still then from the second day, though we used to give them the tablet to take at home, but we used to say them that there could be the chance of reaction also. And if there is any problem, then you have to go to hospital. So on day 2, we used to give 600 international unit at home, day 3, 900, day 4 onwards, 1000 international unit at home to be continued daily for 3 months. And then we used to prescribe 1000 international unit twice a week for at least 2 to 3 years. Next slide, please. So this is the very long duration of this therapy. So definitely there are some limitations there in case of the this immunotherapy. The main thing is the cost, because it's quite expensive, and the frequency of treatment is also there, because patient has to this follow for a long time, and he has to go for a 2 or 3 years treatment. So chance of dropout is high. And the next, the patient compliance. Patient used to, because the symptoms control issue is also there, because the symptoms, they don't control in the 1 or 2 days. It will take sometimes near about 3 months or sometimes 6 months also. So the patient compliance is also the issue. And the next is the chance of anaphylaxis. As I have already mentioned that in the literature, it has mentioned that the chance of anaphylaxis is 0.056%, but there is still a chance. So we have to think about that. Thank you.
I think can I ask a few questions to Dr. Bikash, if you have time, if you allow me? One question.
I think we are going to, just like we are running out of time, we'll ask in last. But one thing that we have to understand is that immunotherapy and pharmacology therapy has to go simultaneously. It is not that we are not giving any pharmacotherapy and we are going in only immunotherapy, because the participant has to understand this. It is the pharmacotherapy and immunotherapy going simultaneously. When the immunotherapy will work, then we'll gradually withdraw the pharmacotherapy. It is the thing that everybody has to understand.
Yeah, the medication would continue, and the medication score that normally would use would increase as the time goes by.
Yeah. So this question goes to Dr. URMILA, because we see a lot of the patient, 30 to 40% of the pregnant female having some sort of rhinitis. So how do you manage the case of allergic rhinitis in pregnancy?
Okay, so 20 to 30% of pregnant ladies do continue having allergic rhinitis, and it has to be dealt as well, because it can exacerbate coexisting asthma, and which consequently can lead to bad pregnancy outcomes. It can cause persistent nasal blockage, so can disrupt sleep, and also consequently have gestational hypertension, which are not the things that we want in pregnancy. Next slide, please. But having said that, pregnancy is a special time for the whole family. So you have to find the benefit of the drug to outweigh the risk. It's not easy to prescribe any kind of medication to pregnant ladies, and there are certain guidelines that you have to follow. Like the FDA says, category A and B are safe to give to the pregnant ladies, and nothing else beyond that. Next slide, please. So the first thing that we try in pregnant ladies is non-pharmacological therapies, which would probably involve avoidance of allergens. This would help in case they have mild symptoms. And the other options are being hypertonic nasal saline douche, physical exercises that would cause vasoconstriction within the nasal mucosa, so probably that would open up the nasal cavity. There are adhesive, external adhesive nasal dilators in the market, probably not in Nepal, but in other foreign countries, which can be used to open up the nasal cavity. And having the head end of the bed elevated would probably also help. Next slide, please. And for the medications, the options that we have in Nepal is probably the intranasal steroids. FDA has labeled it as B category of drug for intranasal steroids, and the use of intranasal steroids is prompted more so because those pregnant ladies who have asthma, they continue to have steroid inhalers with no bad consequences. So probably intranasal steroids is safe for the ladies to continue. But if there is a choice, it's better to use after second trimester of pregnancy. And more so because these patients would develop these kind of symptoms more in the nasal in the second trimester or towards the end of third trimester. And oral steroids are not indicated as they have teratogenic effect shown in the studies. And first generation antihistamine probably is not too popular because of the sedation as the side effect. Next slide, please. So second line therapy, if the steroids do not work, we can use nasal decongestant for acute relief. So it has been labeled as FDAC. So until and unless it's really required, it's not advisable to use it. The other option we have is the second generation antihistamine, more so cetirizine and loratadine, and ideally should be started only after second trimester. So first trimester is a crucial period where you try to avoid the medication as much as possible. And I think the non-pharmacological techniques do help because they tend to have milder symptoms in the first trimester. And with regard to immunotherapy, if the patient is already on immunotherapy, the dose, they can continue with the immunotherapy, but the dose should not be increased. But if they have not had it started, it should not be initiated. And the other important thing is it cannot be used as a preventive measure to avoid development of atopy in the child that is to be born. Next slide, please. I think that's the end of my slide.
Yeah, so the main thing is that mainstay is that what we were using is that we're using the decongestant to the patient. So that is category C drug. So we should be very we should take a precaution about not using a decongestant like diclofenac for acute relief, because it is category 3 according to the FDA. In comparison, if we use a loratadine, desloratadine or a cetirizine, that is considered much more safer than it, because it's category B.
So this is because they normally have nasal blockage as the main symptom. So in that case, probably the antihistamine may not be that effective. So this is so as it's categorized as C. So only if there is acute if acute relief is necessary, because the other option that we have, which can be with nasal blockage can be dealt with, is the intranasal steroid. So probably that would be a better option. And also,
otherwise we go for this first line of therapy, awareness of the allergens, hypertonic douches, physical exercise, head elevation.
Yes.
Okay.
As much.
Because we are so scared to see a pregnancy with allergic rhinitis and the fear of getting problem with some drugs. So So this question goes to Dr. Rishi, because allergy is very, very common in children. And sometimes it is so hard to differentiate, because the child, they usually get 7 to 8 attacks of the rhinitis every year. So that is allergic rhinitis, or that is a other form of the rhinitis. So how do you manage a case of allergic rhinitis in a child?
Well, childhood is a golden period and should not be spoiled with a troublesome disease like allergic rhinitis. But however, it's a disease of childhood and young adulthood, and it's been shown like 80 to 90% of the children with allergic rhinitis will continue into adulthood as well. But the first and foremost thing that we need to know is there are other 2 conditions which may be associated with it or may be mimicking allergic rhinitis, that is adenoidal hypertrophy and acute infective rhinitis. So with proper history and examination that already been mentioned, you need to differentiate between these 2 conditions. And next slide, please. Regarding the treatment algorithm is almost the same as for the adult. Some medications that are slightly safer in children has to be considered. Children, they do not like to use nasal spray, and the proper way of doing it by themselves is also difficult. So better to start with oral medications, that too in syrup in a younger child, and older child maybe tablets. We usually start with second generation antihistaminic. Now when we need steroid spray, the fluticasone is the safer one from the young age group, as young as 4 years of age, while mometasone, which is available here, can be used after 6 years of age, and this should be steroid of choice. And as like the adults, is the same thing that we can continue in the same algorithm can be continued in children. Regarding the growth delay, if the patient is getting steroid from other areas also, like atopic rhinitis, conjunctivitis, then may have to think of growth delay. Otherwise, just purely using a steroid spray for allergic rhinitis only is not going to affect his growth unless it's the beclomethasone. Regarding immunotherapy, subcutaneous immunotherapy is not recommended under 5 years of children, while sublingual immunotherapy is being used and has got shown to be having promising results with the newer studies, but still the efficacy in younger children is not certain. But that still the preferred immunotherapy modality is the sublingual one.
Okay. So in a nutshell, what we can say that is, in child we can start with second generation antihistaminic and intranasal corticosteroids according to the age. So the lowest age group where the second generation antihistaminic, preferably levocetirizine and desloratadine, can be used from the 6th month of the age. And regarding the intranasal corticosteroids, the European Academy and American Academy, they differ. The European Academy, they allow the mometasone that could be used after 2 years of the age, and American Academy after the 4 years of the age. So, so whatever are compatible, I think the participant can choose on that.
And regarding Montelukast, should not be used like less than 6 years.
Exactly. Yeah, the Montelukast. So we have a few questions from our participant. So I think the most of the question has been already answered. So we have got more than 50 questions out here, and on the topic starting from Ayurveda medications and what is your efficacy of Montelukast, How do you differentiate between allergic and non-allergic rhinitis? Role of a skin prick test? I think most of the question has already been answered. Dr. Dipesh has suggested that dairy products increase the mucus secretion, so should we avoid it in a patient with allergic rhinitis? And I think most of the thing has I think has already been answered. And one question is from Dr. Dipesh again. Do you send TFT in patient with allergic rhinitis? And any thought about Manuka honey for allergic rhinitis? I think all of us have limited idea on honey in allergic rhinitis, but do you send a TFT, thyroid function test?
Well, I think one of the cause, as I said, hypothyroidism is one of the cause for rhinitis. So in that case, to rule out hypothyroidism, it could be useful.
Okay. There was one question from Dr. Bipin Koirala from Biratnagar. Efficacy of diodide laser. I think he was asking about the efficacy of diodide laser in reduction of the infrared turbinate. I think any modalities of infrared turbinate reduction could be used.
Depends on the surgeon. It's a different topic altogether.
So there was a small comment from Dr. Davis from Pokhara. All of you look so tired. Thank you, sir. Thank you for bearing with us.
We're not tired, actually.
Yeah, and there is a Dr. Bimal. He has got commented on role of short-term steroids in refractory cases. I think we have already discussed on this. I think most of the thing has already been discussed. So I think today we had a very long session, very nice session. Thank you for being such a wonderful panelist, and thank you for giving us your Saturday evening for 2 hours with us. And I like to announce that we are 211 participants right now online. So the panelist has been, there were 211 people watching the panelist answer. So I like to thank all the participants also. And I especially like to thank CIPLA for this.
Okay, thank you so much, Dr. Yogesh, Seoul, Nepal, and CIPLA, and all the participants who spared their Saturday evening to listen to what we had to say about allergic rhinitis. Thank you so much. And thank you other panelists as well, Dr. Bikash and Dr. Rishi.
Thank you so much.
Actually, it was like a reunion, online reunion.
Yes, definitely.
Alumni.
Thank you, Seoul, Nepal, for putting this platform, Dr. Yogesh, CIPLA, everyone. And as a closing remark, I just want to say one thing regarding allergic rhinitis and COVID. Like if you have allergic rhinitis patient, you need to treat it at the most priority, because if they sneeze a lot, they are going to be the potential virus spreader.
Yeah, true.
So allergic rhinitis patient has to be better treated in this COVID scenario.
Yes, with telemedicine. I would suggest telemedicine for consultation rather than seeing the patient.
Yes.
And thank you all the participants who came up with such a huge number. And maybe some questions that not had been answered, you can send in the Seoul WhatsApp group, and we can answer there as well. And thank you, Yogesh. Thank you, everyone. Thank you, Dr. URMILA and Dr. BIKASH.
Yeah, thank you, Yogesh, Seoul, Nepal, Dr. URMILA, Dr. Rishi, and all the participants for such a great evening. Yeah.
Okay, thank you. See you again. Bye-bye.
Okay, bye.